I know post-lunch session can be pretty exhausting, but we can assure you that we have such a pretty amazing speaker who won't let you doze off. I am Christina Runner, a national officer at Walter E. Dandy Neurosurgical Club, India, and I welcome all of you to event 2 of day 3 of Neurofest 2021, presented to you by Walter E. Dandy Neurosurgical Club, India, in collaboration with Walter Kluwer's. Today is Dr. Kadambini Ganguly's birthday, and she is India's first female doctor. And to mark her birth anniversary, we have India's most magnificent neurosurgeon of all time, Dr. Suchanda Bhattacharya. I welcome you, ma'am. Dr. Suchanda, ma'am, is Professor of Neurosurgery at Nizam Institute of Medical Sciences, Hyderabad. She has done DNB in Neurosurgery at Nizam Institute of Hyderabad, India. She is also fellow at American Association of Neurosurgeon, also visiting fellowship in pediatric neurosurgery, Israel and Canada. She has special interest in pediatric neurosurgery, epilepsy, and cerebrovascular surgery. She has experience as a faculty of over 14 years. She has Best Paper Award in platform presentation in national conferences, publication in various national and international journals, and examiner for MCH in DMD neurosurgery exams. She has membership of Neurosurgical Society of India, Indian Society for Pediatric Neurosurgery, Cerebrovascular Society of India, Neurotrauma Society of India, International Society of Pediatric Neurosurgery, and ISPN membership committee co-chair. The stage is all yours, ma'am. We welcome you.
Thank you, everyone. Thank you, Christina, Bhavya, and rest of the officials of um, Walter Dandy Society, the medical wing. It's indeed a pleasure, to continue. Can I share the screen? Yeah. Can you stop sharing the screen? Then I'll share it mine. Okay. So it's indeed a pleasure to talk to young minds who are thinking of a career in neurosurgery. I hope so. And it really, away from the routine speeches you give in your classes or to a bunch of neurosurgeons, but here we are having some fresh minds who are join neurosurgery, I believe, and it's really amazing that you all have floated this group. You have included me. I'm really joyed to present before you all. So initially, you guys have given me something to talk about innovations in neurosurgery. But I saw there was a talk on innovations, and I have listened to what my dear friend Deepak has spoken. It was really good. And I did think that it might clash of ideas because we all, and so I decided that I need to bring before you certain things which are very basic, and for going into neurosurgery practicing, those things really need to be looked at with a more seriousness, because over my years of teaching, I realized that examination and history is gradually taking a backseat in front of the diagnostics. And that's where we tend to make mistakes. So I will focus my talk on how to examine a neurological patient, which is of utmost importance, with some examples here and there, so that you maintain your interest. And I think 50 or 60% of you become a neurosurgeon from this group who is listening to me today. So, the first and foremost thing I think all of us need to know is that we should not do any harm. If anyone has not read this book, I recommend all of you to read this book. These are Stories of Life, Death, and Brain Surgery by Henry Marsh. And I'm sure it's a very interesting book, and you should go through it before you decide to delve into neurosurgery. And while the Penfield has said the brain is the organ of destiny, it holds within its humming mechanism secrets that will determine the future of human race. how true it is. And Deepak has shown already in his slides. I have gone, listen to him that, if you think in your mind, you can do many things. So, what is all neurosurgery about? I know by now, by these 3 days, you must be knowing what is neurosurgery about. But most of the people think it's just brain surgery, but it is much more. It's defined as a medical specialty concerned with the diagnosis and treatment of patients with injury to or disease or disorders of the brain, spinal cord, and spinal column and peripheral nerves within all parts of the body. The specialty of neurosurgical care includes both adult and pediatric patients. Dependent upon the nature of the injury or disease, a neurological surgeon may provide surgical or even non surgical care. So, this is the definition of neurosurgery, and it's not just brain surgery. So now let's come to this organization, the Walter E. Dendy Neurosurgical Society. So this is the vision which you have, and it seeks to become a forum for neurological surgeons who, by working collaboratively, will enhance the education of both neurosurgical residents and fully trained neurosurgeons, which this you are doing as a part of this program. The teaching of neurosurgical anatomy, operative techniques, and take part in development guidelines for clinical decision making utilizing the best available science. So I thought that this clinical decision making is the most important thing for a neurosurgeon, and I will concentrate my talk on this. So you have these divisions. I will touch upon a few examples of all this and try to say that how decision making is important and how we make decisions in a daily practical clinical scenario. So, what do we need to know in the beginning? You cannot get away without history. History, examination, then comes interpretation of the imageology and investigations, then is decision making, then consent, which is very important and gaining importance day by day, operative preparation, surgery, post operative care, and then follow up. So history, it almost makes to 80% of the diagnosis. What patient or relative says gives the clue. It's only that we need to be attentive and we need to correlate with our anatomical and functional knowledge, what we have gained over the years through our studies, that what the patient says is fitting into a particular set of diagnosis, of differential diagnosis, and from there we a diagnosis. So history cannot be avoided, and we have to remember throughout our life that history is the most important thing. Examination, again, neurological examination plus systemic examination. You need to do a detailed neurological examination, even though we have in improving images and many of the OPD diagnosis has become based on imageology, fair enough, but still many times, without examination, we cannot make a correct decision. Hence, is the importance of any neurological examination, which broadly includes examination of the higher mental functions, cranial nerve exam, motor system, the reflexes, the sensory system, the cerebellar, and other things of importance in neurosurgery, like or neurology for that matter, the meningeal sites, how the patient works, skull, how is the skull, how is the spine, how is the respiratory function, autonomic functions, skin changes, deformity. So we need to have a comprehensive examination of all this to arrive at a diagnosis before we work offer the management. So then there are certain areas in neurosurgery or neurology where you it's difficult. You have to do an examination, but ye- examination. But how do you do in a comatose patient? How do you examine? These are the gray areas, and this is how what we need to know and what we need to learn. How to examine a comatose patient, because many of the patients coming to us are comatose and they're not in a position to tell us. So, what is unconsciousness? Unconsciousness is a state in which a patient is totally unaware of both self and external surroundings and unable to respond meaningfully to external stimuli. There are various states Of consciousness, like drowsiness, they can respond to verbal stimuli, although slow and inappropriate. Stupor, the subject may be aroused only by vigorous and repeated noxious stimuli. Coma, unarousable and unresponsive, and confusion and inability to think with customary speed, clarity, and coherence. The patient may come in any of most of the brain tumor patients, many of them, not most, can come in any of this, and you need to make a correct examination. So, hence, you need to know how to perform a neurological examination. So, how do you examine? Again, the history from the relative is the most vital part. Graded examination of response to incremental stimulus, which includes main the eye response to auditory stimulus, and possible to examine, and I tell you it is possible to examine almost all cranial nerves and peripheral nervous system in an unconscious patient. I will not go into the details of examination, obviously, that comes later, but I will just touch upon all these things. So what do? You take a history and physical examination is obtained. Like for in a case of a severely injured, intubated, or non-communicative unconscious patient, the history is gathered from the witnesses or the first responders. The admission Glasgow Coma Scale and pupillary examination are the most predictive of outcome. And unless a patient can reliably follow commands and report neck pain, and the absence of any injuries, you cannot clear the patient, and the spine needs to be cannot be cleared without seeing the imaging. So that's why the examination is so very important. How do we assess an unconscious patient? Like you have those scales like Glasgow Coma scale or the four scales where you can see the brainstem relax and the respiration, and here is all this response. I'm sure as if you all are in the final years, you must be knowing about that, and you must have learned about that little bit. So this is how there's a little bit of Glasgow Coma and four score. These are very important handy scores which we use which a neurosurgeon use day in and day out in the ER, that is the emergency room. So you should be knowing of all these things, that is decerebrate rigidity, which is fully developed from and consists of this posture and decorticate with arms or arms in flexion and adduction, and legs are extended. So this remains the posture of a decerebrate rigidity and this of decorticate rigidity. So we need to know all these basic things while dealing with the case of neurosurgery. Then in an unconscious patient, the most important thing remains pupil. You need to see how the pupil, if it is normal, round and reactive vision. If it is thalamic lesion, it could be small, reactive, pontine. They're point pupils, and if there's a herniation, then one side may be dilated and fixed and the other side normal. So these are the various signs which guides you. Then you have the doll's eye movement, and then contralateral eye movement with the head turn, and if there is abnormal eye movement, if there is a head turn on the opposite side is normal, if there is no eye movement, it is abnormal. So this gives you that the brain stem is intact or not. You have the oculovestibular reflex, like putting water either cold or hot inside the ear, and you see the movement of the pupil. Then you have the respiration. I'm sure you must have read in your physiology the various types of respiration, and the various types of respiration tells us where the lesion probability is. Then you have the reflexes. It could be either intrinsic brainstem, supratentorial, or extrinsic brainstem reflexes. And if the reflexes are positive, then you should look for if there is any hemiparesis. It could be a supratentorial lesion. If there is no lateralizing signs, it could be any metabolic, toxic, or infective. If there are meningeal signs, positive or negative. That's roughly how you actually arrive at a diagnosis. Now, the another important area is pediatric cases. How do you examine them? It is not easy to examine neurologically a pediatric case. Clinical assessment of the newborn infant and older child are different. So you should know the history of the exact age of the neonate, whether it's a preterm, it is a term, events during pregnancy and delivery, perinatal course, family history. then normal development of the preterm infant. There are some guidelines which tells us like which is equivalent to the term baby, and then you have the developmental milestones, you have the growth curve. These are of paramount importance, which you need to know in examining a pediatric case. Like Glasgow Coma Scale is different in adults and in children, and which you need to be aware in an emergency setting. Like a child will not be same. How do you see in adults? Like it could be four to speech means three, to pain means two, and none means. Similarly, for this one, the child, the neonate cannot speak. So then you'll see the response to sound. So there are some differences between the adults and the infants, which you need to know in assessing a neonate or an infant. Like in motor, for the highest, this one, in adults, the person will be able to follow the command, but for infants, what you see for the spontaneous movement, whether localizing, here you will see withdraws to touch, withdraws to pain, and then of course abnormal flexion extension remains the same. So this is variations you one needs to be aware of. So interpreting that next comes, once you are done with your examination, you have to interpret the immunogeology. I'm not going to speak about this because I know you have a lecture in the evening on CT scans and stuff. So I would not like to speak on that. So I'm just skipping this part. Then once you have your investigation, your history, your examination, you have to make a decision. The decision could be surgical or non-surgical. Surgical could be again open surgery or minimally invasive surgery. Non-surgical could be observation. It could be just a simple reassurance, which is very vital, or it could be some allied specialities are required, like where you do a combination of you join hands with your other colleagues and you have to do the surgery. So all this helps you in making a decision, which is the most important part. So what to do, who should do, how to do. These are the three questions which should always ring in your mind to make a correct decision, and of course, when to do. So, this for what, when, how, who, if you know, then you know that you are in the correct line of thought. Next come is consent, and consent is very very important, and it is becoming more and more important with all the litigation cases coming up. So what is a consent? I'll go a little bit detail about this. An informed consent is a legal term that is supported by jurisdiction in international laws and is described as voluntary authorization by a patient or a research subject with full comprehension of the risks involved for diagnostic or investigative procedures and for medical and surgical treatment. So, the medical consent form is merely evidence that the process of consent occurred, while the dialogue between the patient and the physician is the core of the surgical informed consent process. So information to the patient, we need to give the proper information to the patient. It could be either counseling or it could be a consent. These are different. Counseling is like it is objective. You are having a conversation of the patient, but the conversation gives you a bonding with the patients and the relatives, and it's an emotional thing. Consent, whereas it's an objective, it defends you in a court of law and it's a professional. So you have to be very clear in your mind about counseling and consent. So now let me show you this example. Like we get to see, this is a rowdy attendant who have just destroyed one of the hospital buildings in every now and then about these things happening in the country, in some city or some town, or the doctors being beaten up. Here comes the role of consent. Now, you see, this particular caused in the hospitals is the doctors are creating a beautiful counseling session and having the consent in front of the video. And that so this very particular thing will help the doctors get out of the mess. No one can actually penalize them in the court because they had taken, they had explained. After that, the patient did not do well. So you have to know that consent is so very important. Obstacles to a possible good consent, but then it's not very easy to take into account many obstacles. Like there could be discrepancy between the patient's understanding and the retention of information. The patient's comprehension of information can be influenced by many unforeseen factors, including the patient's personal life experiences and biases. Most of them, they will get, when you will be speaking to them, they will give examples of mere chacha ko aisa hua tha, mere kaka ko aisa tha. So all those actually,
Ma'am, I'm really sorry to interrupt. Your voice like it has decreased in intensity.
okay. Are you hearing now?
Yes, ma'am, it's better than before.
Okay. So patients seldom have enough time to process all the information they're given and deliberate on their decision. Patient can even have the matter of consent thrust upon them on the way to the operating room, at which point refusal is practically impossible. So you have to take care of all this while writing a consent. Then what are the obstacles to as continuing from this? There could be some linguistic barriers caused by the medical jargon which we use many times. We use very hi-fi medical terms which might not be understandable to the patient or the relative. So you have to be very simple language to make them understand. Cultural discrepancies between the patient and physician. Physician is a stranger mostly, so all these things you have to keep in mind. And there is a doctor factor. Physicians have little time to communicate fully and sensitively with their patients, as this communication must be sandwiched between their other diagnostic and therapeutic agendas. So we have to try to give a little bit of time and explain in details to the patient or the relatives before taking them up for surgery, because that helps to solve. You have a bond. You It helps to solve a lot of problem if you have a correct communication with the patient. So all these things are to be really taken into mind before you embark your final career in any field of surgery. So, but then there are some disadvantages also. When you talk in length to the patient, sometimes there's a negative placebo effect. The psychological burden of fear and stress can diminish competence, which means that patient can still make irrational and harmful choices after being given information. Patients come to the hospital for treatment, not education. Therefore, patient can often be uncooperative during this informed consent process and lack interest in listening to the information provided by the physician. Patients are also unlikely to read the informed consent form as meticulously as they should. So we should keep all these things in mind. So what are these preconditions? There should be competence, there should be voluntariness, informational elements like disclosure of all information, recommendation of a care plan, understanding of this information by the patient, and consent element should be decision by the patient, authorization by the patient to proceed. So these are the formal. So what are the different types of consent? There could be written formal signature, okay, a note just in medical chart with signature. In India, both is practiced. There is no uniform protocol though. So now let us see the hard facts. Can you see the so many litigations happen? So if you look at neurosurgery, and 12% of cases compared to other, this one shared that this was published in Journal of Neurosurgery, and you see 12% of cases you can undergo litigation and all this fines and all these things. To avoid this, consent is very, very important. So now unfortunately, this is my department, and this was one of the badly written consent, and I thought that if I am an attendant, I don't understand anything of this handwriting, right? So this was one of the residents. So this will not work out. So now we do have a formal, good consent paper, consent which is typed and all these things. But this was the tradition. Still now we do have a handwritten consent, so that there is like the residents do write it. But if you write it like this is of no purpose, because you cannot understand half the handwriting. So I just picked it up to explain that this consent will not help us anyway. So as I told you before, so these are again all the criteria of having a good consent. So now what is the most difficult thing in doing a neurosurgery? I told about counsel and I told about consent as well as counseling. The most difficult thing is when you operate on a baby and then you have to say, I'm truly sorry, but your child has a brain tumor. You know, you also go through an emotional trauma. And the second difficult thing remains your child requires a brain surgery. So you have to spend time on this factor, which as a busy practitioner, we all are forgetting day by day. And we do not spend enough time with the patient or the relative. So this I would request everyone to keep in mind because this is very, very important. So now let's finish with the consent. Now let's come to surgery. So what are the requisites for a good brain surgery? You should have a strong clinical and imagological correlation. You should possibly have the best of images, like it could be, of course it's MRIs, like the bread and butter you can say of imaging in neurosurgery, plain contrast, so many advanced sequences are there. CT scan sometimes, angiogram, 4 vessel angiogram, x-rays, preoperative mapping. Okay, these are all customized according to the case, but all these things make the requisites for a good brain surgery. What are the intraoperative requisites you require? You require very competent anesthetists, especially in case of pediatrics. Trained nurses, you need very good instruments, you need navigation tools. It could be image guided or real-time guided. Intraoperative MRI or neuromonitoring, good hemostatic agents, so that if you have bleeding, they can control it, and you need a good closure elements. So all these things are requisites for your surgery. So now there are some special situations. And again, I brought this into because we cannot generalize things. When you are operating on babies less than 2 years of age, it requires a totally different approach. Why? Because they present usual characteristics of babies, or they present more with large head and behavioral disturbances. They present less with neurological features, and they are usually have larger dimensions of the tumor in case of brain. What are the challenges? They have very small circulating blood volume, they have poor thermoregulation, they have incomplete skull maturity, cortical mapping and stereotatic guidance are rarely possible in less than 2 years of age. So overall outcome is worse compared to older children. So you need to keep all this in mind when you are operating on very young children, young kids. And they cannot be like miniaturized adult version and you take it as a similar. You have to keep all this in mind. What to do when babies are operated? Then you should ideally give an ambient room temperature. It should be elevated. You should pre-warm the preparatory scrub solutions. You should use warm air currents or convective warming blankets. You should use heating elements not in direct contact with skin. And ideally, you should use warm fluid and blood during administration. These are the things with extra precautions you need to take. Now, again, you in neurosurgery, when you operate on the brain, you need to fix the head, which I think most of you know. And the head fixation is a definite challenge in babies. Why? Because pins may cause, puncture the thin skull and cause bleeding, and cause an extradural hematoma. If used, use more number of pins so that the force is dispersed, the torsional force is dispersed. There are now available specially designed pins. There are cushioned horseshoes available. There are vacuum sandbags available so that you do not need to pin and fix the patient. Like this is a horseshoe where you place the baby and you can operate, and it is adequate for most of the surgeries. Or this is a vacuum filled bag where you can make the patient lie prone and you can get almost the surface of the head. So this helps in your surgery fixation. Now another problematic area is eloquent cortex surgery. You know the brain is full of eloquent areas, the functional areas, and a little bit of damage in those particular portions can lead to a huge deficit. So now let us know what is an eloquent cortex. Eloquent cortex refers to any cortical area in which injury produces symptomatic cognitive or motor deficit. Eloquent areas include primary sensory motor cortex, the homunculus, and you know where are the different areas in the brain. So the primary sensory motor cortex, the motor premotor cortex, cingulate cortex, insular area, essential language areas, occipital, visual areas, and mesial temporal regions are crucial for episodic memory. So all these are eloquent areas, and when you operate, you need special techniques to operate in such areas. So you have to do a planning like pre-operative and intraoperative. Like for cortex, you can, when you are operating on the brain, for the cortex, you have functional MRI, and you have cortical stimulation intraoperative you can do, and stimulate the area and see which area it is you are working on. Subcortically, you have the diffusion tensor imaging. Also, you can do subcortical stimulation intraoperatively. And vascularity, you have the magnetic MRV, venography, and here you have the navigation intraoperatively. All these are tools which guides you in a safe neurosurgery. Now let us take this example. This is a glioma of the brain, a brain tumor, glioma, the most commonest one in the motor cortex. And so you have to do a functional MRI and see where the motor area shifted. This is the functional MRI. It is shifted posteriorly, so your surgery should not come and hit this area. It should be limited to this area, and you have definite techniques for them. Like this is the speech mapping in a particular case where you do, and so that you know where the speech area is, and during surgery you should not be traversing those areas. So this is an example of a DTI which guides you, and this is the lesion. You know where the tracks are, so you can avoid those areas. So this is how it helps. Now intraoperative neuromonitoring, which is a very important, and these are all new innovations in neurosurgery, and they helps to give you a deficit less surgery, and you can monitor the integrity of the neural pathway during cranial, spinal, and vascular process, and helps to monitor, identify, and prevent iatrogenic injury to neurological tissues and blood supply to it. A thorough knowledge of the physics and physiology behind these techniques is actually required to have a better outcome and successful implementation in neurosurgical procedures. So these are the various neuromonitoring you can have, like mapping or monitoring. All these are like you can do the sensory system, the brain stem, the visual system, or the motor system, or the muscles. Everything can be monitored this day. Most of the things can be monitored these days with the latest technology whatever we are having. So these are the common procedures what we in neurosurgery we do with monitoring. And let me skip that. So now let us come to trauma, which all of us encounter, you will be encountering wherever you are in your medical practice, and it usually comprises of head injury, spinal cord injury, peripheral nerve injury. So traumatic brain injury is a major unmet medical need, and this is the statistics. We do not have good statistics of Asia or India in the literature, and whatever we have is not the true representations because many go unreported, and they have sequelae like post-traumatic epilepsy or many other cognitive deficiencies. Burden is significant, yet the awareness is lacking. That is the reason why I brought in the trauma to speak to you all. So roughly this was one published data. So I just bought this, but whatever we have is newspaper data. We do not have very good data representative in India as of now. What is the trauma? If you search, you will not get a correct picture. So you know all these motor vehicular accidents and all these things are responsible for trauma. So the decision making is most important in in a particular case of how you handle it. And I will go through a few examples to show you like what we face on a daily basis in an ER or in a neurosurgical setup in dealing with such cases. Now, this is a 19-year-old boy who came with collision of motorbike on a divider. Brief period, just a brief period of unconsciousness, no focal neurological deficit. He's irritable, his GCS is full, that is 15 on 15. So what investigations do you do? You will do a CT scan definitely, and then you will see whatever. This looks essentially normal. There is some depressed fracture here. So next is, what is the management plan? This is how you proceed for a case. You do an observation, you do a medical management, you do a surgery. In case of medical management, whether you need to give mannitol, antibiotics, anti-seizure medications, or other SC inhibitors for so that the CSF production is less if there is CSF leak, or in case of surgery, whether you do a lumbar drainage, you do an open repair or an endoscopic repair if there is a. So these are the various things which comes to your mind when you deal with a case of neurosurgery in the acute setting. Now, let me show you another example. This is 17th year boy, 12th standard. He met with a road traffic accident. He came within 1 hour of injury with GCS3, and this was what it was. And this was a young boy who was coming from his tuition classes, and this was what the GCS was 3. We have no indication for surgery. We know we cannot do anything about it. But since he had come within 1 hour of injury, we just gave a benefit of doubt and we operated and we saw there was a huge subdural hematoma. And of course, he did not survive, and it was quite expected that he will not survive. So this within 1 hour. So we took a chance. Otherwise, there was no point doing it. So this is how you make a decision in an ER. So brain injury could be anything. It could be externally, it could be internally, it could be close primary brain injury, it could be secondary injury, or there could be complications such as CSF leak or pneumocephalus, that is air in the brain, could be infection, could be some fistula or even epilepsy. And these are the things. So what you do, you look for, all of you know what ABC is, and that is the primary survey, and then the protect the neck, then you do the secondary survey, then you do chest and lateral spine in case of neurosurgery. So results of neurological examination, you should look for the level of consciousness, whether there is any deficits, whether how the pupils are, and then you follow the brain trauma foundation guideline. I will not go, cannot go into the details of all this. It will be really boring. And what happens finally, the most brain herniations you should know. If there is a herniation, then it becomes imminent danger and we might lose the patient. But all herniations are not permanent. They can be reversible at timely interventions. So these are the examples of how a brain herniation happens. Like it goes and occupies the cisternal area and compresses on the brain stem, and then finally you can you lose the patient. So these are various examples what you see on everyday life. This is a Cook counter Cook, like you see here one on the anterior part of the skull, some contusion, and then also you see on the posterior part. So these are called Cook counter Cook injury. Then you have this, which is a subdural hematoma. The mortality rate is quite high in this. You have an extradural hematoma like this outside the dura. You need to operate very urgently in these cases. And these are examples of some brain contusions. In the frontal area is very liable to such contusions because they have lot of bumpy bones over here, and that is the reason, because of the friction between the bone and the brain here, you get a lot of contusions, and they may be dangerous. Like this is one case where we had operated, we had to do a bifrontal craniotomy, remove the bone, see the contusion here, and this is the post-operative, and the patient becomes all right if timely intervened. This is again a trauma where you can see there is a defect in the cribriform plate. This is the eyes, the cribriform plate, and here's a defect. So a CSF rhinorrhea can happen, and then you need to treat them. This is an example of multiple small. These are shearing damages in the brain where you can see multiple small hemorrhages. Patient remains in coma for a long time in this sort of cases, and then they gradually come out. Usually, if they do not get infected due to hospital acquired infection. This is a depressed fracture case. And this is a case of air in the brain or pneumocephalus. You just need a medical management for this. Mildly prone for seizure, and then this is something which again you need to keep in mind. I'll just tell this story. 6 months girl rolled off couch on the floor, makes funny noises, not breathing properly. Unconscious frontal bulging. What is the probable etiology of unconsciousness? Fell down, you might think head injury, but no, you should look for abuse. This is a big thing. There could be this abuse, and there could be non-accidental trauma to babies, and you should always, these are the retinal hemorrhages you can see. So this This is a non-accidental hemorrhage, and this is abusive head injury. So you have to keep in mind. These are some examples of spinal injury where you can see there's a fracture and there's a dislocation in the CV junction, atlantoaxial dislocation, C2, and this is the atlas, this is the axis, and see there is some dislocation here. So these are the routine things which you get in peripheral nerve. You can get a brachial plexus injury dealt commonly by uh, plastic surgeons as well as the neurosurgeons. Then you have functional neurosurgery, as you have all those, you have all these things which you deal with. I'll not go into the details, where the main thing remains stereotaxy. Stereotaxy based surgeries are being done. Now you might need to know what is stereotaxy. Stereotaxy is stereo literally meaning is taxis, and to move forward means taxi. So you use this instrument and then you, like, it looks something like that. There's a Lexel frame where with the use of this instrument you put the head inside a geometric plane and you calculate the x, y and z axis, and you can reach any area of the brain. So these are the various frames available, and through these are the localizer. You fit it and then you do an MRI or a CT scan, then you can get the coordinates and you can reach any part of the brain. Those inaccessible areas, you can take a biopsy or for put an electrode in case of Parkinsonism, which we call deep brain stimulation, or any, you can remove a foreign body, you can remove hematomas or a cyst with a minimally invasive surgery. There could be complications like hemorrhage and due to damage of blood vessels, and there could be seizures and infections as a consequence of this procedure. So these are some minimally invasive neurosurgery. And then you have the endoscope. In minimally invasive neurosurgery, these are again great innovations of neurosurgery. This is how a neuroendoscope look. With the help of it, with a small burr hole or small hole in the brain, you can actually treat many cases, like making a way when there is an obstruction, then there is ventriculomegaly and there is hydrocephalus. You can make a hole in a different pathway at the floor of the third ventricle. And like if you saw a floor, this is the floor of the funnel, you can make a hole here and you can create a separate pathway for the CSF to communicate. So you can do a biopsy as well as you can make a hole here. Then this is after you can do such big tumors, you can take a biopsy first and then give some medical management, then come again and do and surgery. So the various gimmicks can be done. And this is how an endoscopic picture looks like. Like when you do, this is the basilar artery, you get a hole here. So again, decision making, I will say there are a few examples, like always you have this various methodology. Like this is a case, this is the posterior fossa of the brain, where you can see there's a huge tumor. The answer is clear cut, simple surgery. You don't have any other controversy in this case. Like this particular case, this is a choroid plexus papilloma. Actually, it's a huge case. Usually it's seen in children, it's seen in infants and now here you have what should be the best approach is, because they're very vascular tumor, your best approach should be to attack the blood supply first. So there could be various approaches interhemispheric. So like these are the various technical approaches you have, but you should know that the principle behind it should be to attack the blood vessel first. So accordingly you will uh, approach the case. So this is these are where your decision making is very important. Like again, this is a medulloblastoma case where you need uh, it is a pretty much standardized approach what you take. There is no controversy about it. Now this is a case, you see, this is a large tumor of the pituitary gland. You could do a medical treatment, you could do a surgical treatment, you could do a radiosurgery. Now you need to decide which is the best. Now we did the hormones and we found the prolactins are elevated. So only a medical management suffices. It's on drugs, and then gradually there is, you can see there is a shrinkage of the tumor. This is again another case, a straightforward case where you can just do craniotomy and you can take the tumor. There is controversy on this. Then there are certain sometimes very odd positions you need to keep the patient when you operate on large tumors like this in the pineal region. Just to show, like, this is the supratemporal component, this is the infratemporal component, this is the transverse sinus separating the supratemporal infratemporal component. To get this both the component up and down, you need to have a position, something very odd position, which is fixed with a Mayfield clamp and the theater. So these are the various innovations which has happened in neurosurgery over time, and they help you to achieve better and better result. So this is again a straightforward case, a Ewing sarcoma. This is a huge tumor in a 1-year-old girl. You can see half the brain is of tumor, but they look big, but they can be done with a simple craniotomy. Now, this is again an aneurysm of the brain. Here again, you have to make a decision whether you have to go through an angiogram, which is called endovascular, where you can do coiling, or you can do a microsurgical surgery and you do a clipping. So, at every case level, you have to make a decision of what is best to the patient. Now, this is again a brain tumor surgery I did a week back, and then there are lots of approaches for this, and you need to know which is best and how to decide. Again, a case of, you see, these are the subdural space, these are the subdural hematomas, which you often get in trauma along 2 or 3 months after trauma, and it doesn't require any big surgery. You make 2 or 3 holes in the brain and drain off the fluid, and you can do it under local anesthesia. So I'm just showing you a few examples so that everything is not very difficult in neurosurgery, though many people show that it is very difficult, but there are certain cases which are pretty simple and can be done. Now, this is a case where you see the hardly there is any cortex material. The whole thing is fluid with CSF, ventricles. You cannot make out anything. So what do you do? Again, do you do any surgery? Do you do a shunt? Will the child improve? You can see the trans illumination. You can see the sagittal sinus. There is no cortex. You can see the whole box being filled up with water, like it's the appearance is like this. So does it benefit any merit by doing a surgery? So all these decisions you need to take time and again. Now this particular case, I'll tell you what difficult it was. They presented with weakness of lower limbs, back pain after a fall. Simple symptoms were not correlating when we examined the patient with the fracture side. So at a closer look, we found that there was something else here, and that was responsible. So we had to operate on both. So you have to be very careful in correlating the clinical symptoms with the radiology. Then only you will get a good outcome. So now this is a pituitary adenoma. And you see, this is one case, a huge one. This is the same, another pituitary adenoma, a small one. Now these two are entirely different. This requires a approach from like doing a craniotomy. You open the skull and do this. You can do through the nose, through a transsphenoid, through the nose, through the sphenoid, and then reach the pituitary gland and take out. So everything requires your decision making. This is again a hematoma of the brain. Again, here you may need to make a decision. Why? It is on the left side of the brain. If you operate and come here, you will destroy, and you might destroy the speech area. So you might only have to remove the skull bone and give some space. Whereas if it was on the right side, I could have come in and taken out the clot either through a endoscopy or through an open surgery. But on the left side, again, you have to be very cautious because you have the functional area. So at every case, as I'm telling you again and again, decision making is very important. This patient came with only back pain, and we can see fracture of the bone. So you need to fix this case. So there are, now when this case came to us, this was a thalamic hematoma. You see these are the ventricles which are normal. We did not do anything. But over 3 days, there was a ventriculomegaly. There was a blood within the ventricle. The clot has increased in the hematoma. At this point of time, we intervened and we did a shunt. So everything is it evolves over a period of time. Like this particular case, again an aneurysm, but also has some stenosis in the neck carotid. So you have to decide what is the best. Like the best would be endovascular. You can coil this, and then you can put a stent across this place, but the patient never had money. So what do you do in this case? You have to clip it because that works out to be cheaper. And of course, that is always more curative than the endovascular. So you do this, and then you can address this particular thing. So, like now, this is my last case I want to show. This is a meningioma, looks a big tumor, but only surgery is the option. No second thought about it. Go ahead and operate. So my last message to you all is you should always look outside your box. Always look at not only the images, also the examination, also take care of the consent and history taking, as I tell you, and clinical examination is of utmost importance, even if we have had huge advancements in diagnostics. Decision making comes with experience. Commitment is the priceless armor. Thank you. Hello.
Thank you so much, ma'am, for such a wonderful session. I think we can have the question answers now. Like if anyone wants to ask any question, they can type in the chat box. Or I would suggest that if you guys can like, unmute yourself and talk directly to ma'am, that would be more appreciable. Do we have any questions from anyone? Feel free to ask any question. Ma'am, people are requesting your presentation. I mean, this is the very first speaker to be who's asked for a presentation.
Yeah. I mean, you are recording it, no?
Yes, ma'am, we have recorded it.
Yeah. You can take it. No, I mean, how can I give you the presentation? You tell me, I will give it. I don't have any problem.
No worries. I mean, we will be putting the whole recording over YouTube as well as over our Instagram. So whosoever are interested in the presentation, you can just directly go there and take the screenshots.
Yeah, they can take that. If anyone can write to me, I don't know whether it will go in mail or Google Drive. I'll share. You can take it. No issues.
Awesome, great. Do we have any more questions from anyone else? We have one question that says, any tips for research opportunities in neurosurgery?
Yeah, there are huge steps for research opportunities. Actually, uh, mm, we clinicians, we are so overloaded with the clinical work. We would actually love if students actually come in and do researches, because we can give the material, we can do the guidance, but we do not have the time to do research work. And research makes the basis for innovations, right? So there are a lot of research opportunities. Only you need to be, what I say, you need to be like associated with the institutions. There should be a policy. Like in West, you have this summer breaks. I have seen students, they come in the summer breaks, and wherever they want to make their career, they go to those departments, and then they do some projects, like along with they're tagged to some consultants and they do some projects. That way they learn the art of knowing the particular the nuances of the department, as well as the subject, as well as they get an impetus to grow in that particular field, and they get to do research which leads many times to many new things. So we don't have that culture yet in India, but I'm sure it is starting. Anecdotal representatives are there, and I'm sure it will, in the next few years, this will become more popular. I know, like students coming to the clinical departments and doing research.
Thank you, ma'am, for this input. We have another question that says, what is the scope of surgical planning and virtual 3D reconstruction using 3D printers?
Yeah. I mean, there are a lot of things to say. You do use 3D printers, like when you do in difficult areas like the what you call cranial cervical junction and all. and you need to fix those areas with screws and plates. We do take out 3D printing, we use that, and you take out the models and you do practice it. You know, we like when I do many times, we take a printout of that particular area where we'll operate, where we have to put screws just adjacent to the vertebral artery, and we know it's very difficult. And then we make the sometimes residents do that so that they learn how to do it, and we also practice ourselves and then go inside too. So that memory helps. If you do it today evening and tomorrow you go and operate, you are more confident while doing the surgery and the chances of error are less. Another area is like for learning purposes, we are using 3D. We use 3D printing skulls and all, and do the craniotomy flaps and all to understand. And then we use 3D to reconstruct an aneurysm, and then we plan it like, okay, this sort of clip will be required, that sort of that angled clip will be required. So 3D printing has come in a big way in helping you in doing the surgery. Then you have 3D printing for, like, I did not put those examples here. When you take the skull bone out and sometimes you keep it in the abdomen for a long time to give some space to the brain. So when you reconstruct, invariably in 2 to 3 months, the skull bone shrinks, or sometimes you have to discard the skull bone because it get infected. That time you have now 3D implants which exactly fits to the the cranium defect, and then you do a very good cosmetic surgery. So there are a lot of implications of 3D printing in neurosurgery now.
Thank you, ma'am. We've got another question from Dr. Praveen that says, can you suggest some books where we can learn about neurosurgery?
uh, I mean, it depends on, as a beginner, I think there are books like John Patton, and the handy book which everyone uses as residents is Greenberg, which is widely available. And I don't know if something new has come, but these are the two books which most of the people uses as a beginner for neurosurgery to get an uh, idea of what neurosurgery is. And Greenberg is a pretty commonly used book. Yeah.
And I hope that answers your question. Vaishnavi says, ma'am, if anyone cannot get high marks in NEET PG, then how to perceive neurosurgery?
So that's what we are in a system, and the system we cannot change. Like, you might be very skillful, but you might not do crack the exam well. But then I don't think so there is any other way out for that. You have to do, I mean, there are a lot of centers like now, um, you can take up DNB in a good center, you can take up MCH, but of course, I mean, I don't know, like in India you have to crack an exam, right? Everything is centralized now, so you have to study hard and then join neurosurgery. Everything you get it, you just need to try and be perseverance.
I hope Vaishnavi would be more motivated with ma'am's answer. The next question we have from Dr. Atul Krishna.
I for one, yeah, to that, I for one will, that includes you as well, and Bhavya, and if you ask me my suggestions, I would ask people, if they want to do neurosurgery, is better they do the basic training in India, because the hands-on and the basic skill level what you need is very good in India, and people have started coming from other places to India to learn neurosurgery rather than go out and run. Yes, once you are done, there are a lot of advancements, there are a lot of organized training which you need to which is definitely better in the western part of the world. But yes, if you need to know basic neurosurgery, I think India is a fantastic place.
Thank you, ma'am. That really is much more inspiring. Next question says that, how do you see the scope of polyclinics and peer group hospitals with neurosurgery?
See, polyclinic and peer group hospitals. Since I work in a government hospital and I'm not into a private practice, type of thing, I don't think so I'll be able to answer your question that well. But neurosurgery is a thing which requires a setup, a little bit investment in it. Polyclinic, you can only do OPD practices and certain very, very daycare things, like these days people are doing like pain management and all those stuff, because your degree of infection control and sterility and all is a little bit more precise in neurosurgery than any other specialty. So polyclinic might not be that successful in neurosurgery, and you need a good setup, good investment for, so corporate hospitals are better in the private setup. Yeah, definitely.
Thank you, ma'am. I guess we don't have any more questions. I think we can wait for a minute more if anyone is typing or if anyone wants to ask something. And yes. Meanwhile, Muskan, could you just put in the post-event feedback form so that we can have a validation of their attendance for their achievement of the certificates as a delegate for this conference? Ma'am, we do have another question. That is, will neurosurgery have similar fate like CVTS since interventional neurology is improving?
No way. That will never, neurosurgery can never have that fate. It will never die down. It will never die down, because there are so many things which you cannot do with interventional radiology. That's why I took up those cases, a mixture of cases I bought, just to show where, without neurosurgery it's not possible. I somehow know that these are the questions which goes on in people's mind when they choose specialities, and that's why I bought few cases which showed, like, without neurosurgery there is no other option. Yes, definitely there are few branches which has taken over, and there are a lot of minimally invasive stuffs, but nevertheless it will never die down.
I hope, Dr. Atul, your question is answered. With this, we come to the end of the session. And okay, we do have one more question. That is, any tips for an undergraduate student?
History taking, clinical examination should be your strong point, not based on CT scan or MRI.
I hope, Vaishnavi, your question is answered. I think with this, we come to the end of the event. And it was for sure a very wonderful session, and a very, I would say, the most session that was resonant to us at medical student level. So I'm really honored to again hear from you, ma'am. And it's been a really wonderful session as always. It's been a pleasure to talk to you as usual. So before we end this meeting, I would like that everyone to fill that post-event form that one of my teammates, she's the general secretary for Walter A. Dendy, she just sent a Google form. So everyone please fill it so that we can send you your certificates in time. Till then, stay tuned because we'll be having our final round of the neuro quiz, which was a national level quiz that happened yesterday, with over 700 plus teams, with every team having 2 participants in them. So top 5 teams will be competing live in the next half an hour over YouTube, over Zoom. I would suggest you to come over Zoom because we'll be having prizes for the audience as well. And stay tuned, everybody. And thank you, ma'am. You surely marked very well the birth anniversary of Dr. Kadambini Ganguly. Thank you so much.
Oh, thank you. Thank you so much, Bhavya. All the best to all of you. And I listen to the quiz because I really love quiz, and I do conduct the national level quiz in neurosurgery during the National Neurosurgical Society's annual meeting. Last time we did it, and it was CMC Vellore who cracked it. So I'll definitely be there at 4 to listen what you do.
Awesome, ma'am. I'll share the link with you.
Okay. Thank you very much. Bye-bye.
Thank you, ma'am. Have a good day. I repeat, and I request all the participants to please fill in their forms because we shall be ending the event in the next 2 minutes. That's 3:42 p.m. I repeat, we shall be sending them again at 3:42 p.m. Till then, please take your forms and fill it because I'll be ending the meeting. You won't be able to access thereafter. And no more conditions or no more text would be allowed after that. Thank you, everybody. Muskan, could you please locate